And why don't we get started? My name is Gerard Silvestri. I'm a professor of medicine at the Medical University of South Carolina in Charleston, and I'm really delighted to work with you in this program, this webinar, The Role of the Pulmonologist in Tissue Acquisition, Specimen Handling, and Molecular Testing of Patients with Early Stage Lung Cancer. This is an educational campaign brought to you by CHEST in collaboration with AstraZeneca. I really have a wonderful panel I'd like to present to you today. If we could go to the next slide. And our lead facilitator is Dr. Lonny Yarmus. He's an associate professor of medicine and oncology in the Division of Pulmonary and Critical Care Medicine at Johns Hopkins University School of Medicine. Lonny is an expert in interventional pulmonology, and he's going to be talking to us for the first half of this hour on techniques used to gather tissue for molecular testing in early stage lung cancer. The next slide, please. I'd also like to introduce Peter Illei. He is an associate professor of pathology and oncology at Johns Hopkins University School of Medicine. And Peter is an expert in next generation sequencing and all things pathology, particularly cytopathology, and we're really grateful to have him join us for this webinar. Finally, I'd like to introduce Daniella Molena, the associate professor of thoracic surgery at Memorial Sloan Kettering Cancer Center. And she's going to be talking to us today about surgical aspects of early stage disease, particularly in light of some new data about molecular analysis in these patients. I'd like to turn it over now to Dr. Yarmus and have him take away the early part of this program. Thank you, Lonny.
Great, thanks, Dr. Silvestri, and to the ACCP and AstraZeneca, and to my colleagues on the panel. So I'm going to address the role of the pulmonologist in tissue acquisition, specimen handling, and molecular testing of patients with early stage lung cancer. Here are my disclosures. So some just overall objectives for this talk. I'd like to get into a bit of why a diagnosis of lung cancer may not be good enough for early stage disease, what we could do about it, high yield molecular tests and the results and role that they play, and then spend time discussing techniques for tissue acquisition and specimen processing to optimize mutational analyses. So first, just what are the clinical consequences of occult nodal disease in lung cancer, and why do the diagnostic modalities that we utilize matter? So for advanced stage and specifically N2, N3 disease, poor outcomes of primary surgical treatments are known in stage 3 disease. And specifically in early stage disease and N1 nodal disease, there's growing need for better understanding, specifically for surgical planning for sublobar resection candidates, and we'll address that with Dr. Molena. The growing need for SBRT planning, so especially in those patients that are non-surgical candidates, so understanding not just the primary disease location, but also nodal locations for radiation planning. And then I think there's a growing need and interest in utilizing minimally invasive diagnostics to limit additional procedural interventions to reduce risk. So specifically, as an example, if we can get a firm diagnosis off of a lymph node with EBUS TBNA, historically we could then limit the need for peripheral nodule biopsy, either by bronchoscopy or percutaneous TTNA, which inherently would then reduce potential complications such as bleeding or pneumothorax. So I think most of us are quite familiar with the importance of lung cancer staging, but specifically staging importance for occult nodal disease, specifically clinical T1N0 patients, has a specific growing importance. So this is a nice paper published in 2019 by Roberto Casal's group at MD Anderson, looking at clinical T1N0 patients with nodal disease found on surgical resection. So 596 patients who underwent surgical resection for T1N0, non-small cell lung cancer. And I think not surprisingly to many of us, although the clinical stage was T1N0, the pathologic stage differed significantly. So 83% of those patients remained N0, but 9%, 56 patients, had N1 disease found. And I think more pertinent, 47 patients, or 8%, also had N2 disease. There was differences with central tumors that were associated with the presence of occult nodal disease, but this really brings to light the fact that our presumptive clinical staging doesn't often align with final pathologic staging, and the impact on treatment is significant. We were fortunate to run a multi-center trial that closed this past fall, looking at electromagnetic navigational diagnostics for clinical N0 patients with presumed early stage lung cancer. So the enrollment was patients with presumed stage 1 disease. And as part of the protocol, each of these patients had an EBUS first at the time of bronchoscopy. All patients included were PET negative, CT negative mediastinum inclusion. And if ROSE was negative in those patients, then navigational bronchoscopy was performed. If ROSE was positive, that was considered a nodal diagnosis, and the procedure was aborted. In an interim data analysis that was presented at the 2019 meeting by Jeff Thibodeau, who's one of our interventional pulmonologists at Hopkins, we looked at 58 patients with clinical T1N0 presumed disease, and 8 out of 58, similar numbers, 14% were upstaged, with 7% N1 and 7% N2. So this is really the first prospective look at this from a minimally invasive fashion. So why does EBUS staging matter for early stage disease? Well, there's growing indications and promise for targeted therapy, and we'll spend some time talking about that. There is special attention that should be paid to patients likely to undergo SBRT or non-surgical interventions, as we discussed, given the growing importance of targeted therapy in early stage lung cancer. And I think one of the important roles of EBUS that we're learning now at a faster rate is this is likely a reason for discordance for stage 1 survival. So clinical T1N0 patients, as we presented, nodal disease is present in 14 to 20% of cases. But if you look at the 5-year survival by stage of non-small lung cancer, specifically, I think the 1A1 and 1A2s, inherently those should be in the high 90s, if not 100% 5-year survival. And there's growing thought that much of that discordance is due to inadequate staging. We all think that EBUS has a large growing role to help access lymph nodes that may traditionally not be accessible with surgical techniques. In addition, targeted therapies are now available for patients with advanced disease that harbor certain mutations, and we'll also talk about those interventions for now early stage disease. Most of what we're seeing remains adenocarcinoma with histologic-based subtyping, and of that, there are a growing multitude of biomarkers that are being addressed and looked at, with a rapidly growing market for both approved and emerging therapies for interventions beyond just what we are talking about in the immunotherapeutic regimens. So with the growing need for molecular studies, is there a need for minimally invasive samples in early stage disease to assess targeted therapeutics? So traditionally, when we approach a minimally invasive diagnostic procedure for presumed lung cancer, where EBUS is performed first, if the lymph nodes are positive off of EBUS, our traditional metrics and flow is to utilizing rapid on-site evaluation, which we have the luxury of having here at Hopkins, have that immediate cytologic and histopathologic feedback for not only adequate tissue, but a diagnostic sample, at which point we then move on and take additional samples for mutational analysis to assure that next generation sequencing can be performed. But in the historic literature and practice, if lymph nodes are negative during EBUS or non-diagnostic off of EBUS, then bronchoscopy or TTNA samples, which are positive prior to resection or treatment by radiation, there wasn't a clear need for additional tissue for molecular or mutational markers from the primary because up until now, there wasn't really strong data to support mutational therapeutics for early stage cancer. But what if targeted therapies were available as they are now, and how might that change our practice? So this came, I think, rapidly to light at the end of October with this nice study published in the New England Journal of Medicine looking at osimertinib in resected EGFR mutated non-small cell lung cancer patients. So this was a relatively large double-blinded randomized phase 3 controlled trial of 682 patients who underwent complete resection of EGFR positive non-small cell lung cancer. This was a one-to-one post-resection. Patients either received osimertinib or placebo for 3 years. The primary endpoint was stage 2 to 3A disease-free survival, with secondary endpoints expanding from 1A to 3A disease-free survival. And as you can see at the overview Kaplan-Meier figure on the right, the study met both its primary and secondary endpoints at 24 months. There was a 90% treatment effect with osimertinib versus 44% of patients being alive and disease-free, with a hazard ratio of disease recurrence or death of 0.17. When that's broken down a little bit further in the supplement, this looks specifically in this figure at stage 2 disease. You can see again a nice separation within the Kaplan-Meier between osimertinib and placebo. Again, for stage, this is stage 1B disease. But again, you can see similar primary or secondary outcome met here, with a hazard ratio for disease-free recurrence or death of 0.39. And again, similar outcome data. This is stage 2 disease-free survival with, again, separation and hazard ratio disease recurrence or death of 0.17. So secondary to this data, the FDA on December 18th approved osimertinib as an adjuvant therapy for non-small cell lung cancer with EGFR mutations, which brings a lot of this conversation to light. So based on that, specifically stage 1A and 2A disease-free survival separation, it really brings to question, should we now be thinking about ascertaining tissue sample for mutational analysis for early stage cancer off the primary, and how should we do that? So traditionally we're using EBUS-TBNA for our mediastinal sampling, but when we move past that, there are two main options available: CT-guided biopsy and bronchoscopy. And again, I think many of us are familiar with the multitude of different interventions available with bronchoscopy, from standard fluoroscopy and radial ultrasound to electromagnetic navigation, relatively newly introduced robotic-assisted bronchoscopy, virtual bronchoscopy, and guide sheath bronchoscopy. How we use these, I think, is well represented in this figure, based on a suggested algorithm for local regional lymph node staging and diagnostics for non-small cell. So after imaging, we generally divide patients' imaging into two categories of lymph node suspicious or not suspicious, concentrating more on the right with pathologic appearing lymph nodes. We then look at the clinical stage of these patients. So clinical N0 patients with a peripheral tumor or tumors less than 2 centimeters, traditional guidelines still advocate that those patients can go direct to resection with lymph node dissection. That little hash dotted line there is the growing evidence and the role of EBUS in these patients, given the data that we presented earlier with N1 and N2 disease in this patient population. So these patients now routinely at our center and many others undergo EBUS first, for the most part, regardless of clinical stage. And traditionally, if the mediastinal lymph nodes are negative, as I discussed earlier, those patients may just go straight on to surgery without additional attempts or any attempts at peripheral primary tumor sampling. But with the data presented, this now brings up the debate of whether or not bronchoscopy and or TTNA should be utilized in these circumstances to obtain tissue either pre-surgery or, I think, as if not more important, SBRT patients for radiotherapy to determine their molecular profile of tumor. So I'll spend a little time going through the different options and evidence to ascertain these minimally invasive diagnoses. So this is a nice meta-analysis published by the MUSC group back in 2012, at that point looking at available diagnostic modalities for minimally invasive bronchoscopy. And the overall summary here when looking at virtual bronchoscopic techniques, electromagnetic navigational bronchoscopy, guide sheath, ultra-thin bronchoscopes, or radial EBUS, the overall meta-analysis yields for these cases was about 70%. That's been relatively persistent over time. TTNA is widely regarded as a procedure with a higher diagnostic yield, but certainly a higher complication rate. So this meta-analysis of 65 patients over about 30 years and 13,000 cases showed a sensitivity of CT-guided biopsy of 90%, with a pneumothorax rate of 25% and a chest thoracostomy rate of about 15%. This data, as our techniques in bronchoscopy have evolved, so have some of the TTNA data. And this, I think, was nicely highlighted in a comparative cohort study published by the Cleveland Clinic group back in 2018, looking at electromagnetic navigation versus CT-guided biopsy for percutaneous sampling of peripheral nodules. And the yield here clearly benefited CT-guided biopsy, which I don't think is a surprise to many in the periphery, 86% versus 66%. But I think an important metric that's worthy of pointing out, if you look at the complications, which is generally our reluctance for CT-guided biopsy, the pneumothorax rates for CT-guided biopsy overall in this study was quite high, 43% versus 6% in ENB. But I think the clinically important complication profile is chest tube rates, which interestingly here, the pneumothorax rates for ENB were 4%, and it was actually less, 2% in the CT-guided biopsy. So all of these different procedural techniques are generally safe, effective, and remain on the table. As technology advances, there are new advancements in additional techniques, and this is highlighted here, I think, in a newer procedure using electromagnetic navigation-guided percutaneous lung biopsy, or TTNA. And here we looked at a retrospective cohort of about 130 electromagnetic guided TTNA procedures performed at 10 centers across the United States. The procedure was feasible and performed in all cases. And interestingly, the yield was high and indicative of adequacy consistent with CT-guided results. So 74% overall diagnostic yield based on the electromagnetic guided TTNA procedure alone. And by combining these two procedures with bronchoscopy, so using these procedures in a stepwise fashion of bronchoscopy first with rows, if non-diagnostic, moving on to TTNA, that yield increased to 83%. There are also advances with bronchoscopic procedures, and there's been a lot of interest and enthusiasm in the field, specifically focused on robotic-assisted bronchoscopy. There remains a lot of gaps in the literature comparing robotic-assisted bronchoscopy versus our traditional methods. This was a study that we published last year in CHEST in cadaveric models, looking at a direct randomized comparative study of 3 modalities: radial ultrasound with a thin bronchoscope versus electromagnetic navigational bronchoscopy versus robotic-assisted bronchoscopy in the same cadavers with nodules approximating 1.5 centimeters. And found that indeed robotic-assisted bronchoscopy had a significant benefit for localization and nodule puncture of lesions. So on the figure on the right, on the left, you can see that the robotic-assisted bronchoscopy diagnostic localization and puncture yields were 80% when compared to navigation of electromagnetic navigation of 45% and ultra-thin radial EBUS bronchoscopy of only 25%. The graph on the right, I think, nicely distributes or nicely illustrates the distribution of miss distance based on the precision of these tools, and you can see the superiority of a robotic approach over traditional bronchoscopy for precision and localization of these targets. So utilizing all these different methods and understanding the literature for early stage disease therapeutics, it now begs the question of can and should bronchoscopy be used for mutational analyses in these patients? There's a rapid growing and persistent literature in the field focused on EBUS, which is where most of this literature really lies, and minimally invasive specimens. And I'll just highlight a few. This is one is a retrospective analysis of 209 cytology specimens from patients where mutational analyses were performed with an overall specimen insufficiency rate of 6% or a sufficiency rate of over 93%. And I think it's worthwhile to highlight where those samples were taken. So EBUS had a very high sufficiency rate, 96%, TTNA equally high, and ultrasound guided and superficial FNA of 10%. Interesting as well, that I think Peter will probably highlight, Dr. Illei, is that body fluid here, specifically pleural fluid, has an extremely high sufficiency rate for mutational analyses. Another study of 156 EBUS cases utilizing a small needle, so 22 gauge needle, also showed adequacy specific to EGFR analysis in 98%. ROSE, or rapid on-site evaluation, provides an immediate cytologic evaluation with rapid staining methods. We utilize this on every procedure that we do here. There's a lot of literature in the field that's really focused not on the utilization of ROSE for diagnostic yield per se, but to help guide the procedure during that interface to define adequacy of the specimens, provide a preliminary diagnosis, and I think most importantly to give us feedback to determine that we have sufficient tissue to run mutational analyses, and then ideally to avoid other bronchoscopic sampling techniques, as I suggested earlier. If we can define that a lymph node is positive and assure that we have enough tissue for ancillary analysis, we can avoid the risks of peripheral procedures. A study that we had done a few years back looked at 80 adenocarcinoma patients retrospectively who had an EBUS diagnosis to try and determine some of the metrics to define how we are able to have such high outcome yields for mutational analyses. So in this study, we had over a 96% adequacy rate for all mutational analyses. much of that is due to the Rose feedback with a minimum of 4 passes, and current guidelines are consistent with this now, using this data, suggesting that a minimum of 4 passes off of a diagnostic lymph node is needed to ensure that adequate tissue is obtained. Focusing on specimen preparation. So once we hand the needle, whether it's a bronchoscopic peripheral needle or a transbronchial biopsy or specifically an EBUS needle, off to our colleagues for on-site analysis and preservation, what is the optimal way to do this? So there's air-dried smear techniques, alcohol-fixed formalin cell blocks or core, and other mediums such as Normasol or RPMI for flow cytometric data for lymphoma workup. So it's critical as a proceduralist to ensure that we are familiar with these techniques, to have open conversations with our pathologic colleagues and our oncologic colleagues to ensure that we are sending the appropriate tests as well as the appropriate amount of specimen. How these techniques are prepared is of growing interest to many of us, and there's a guideline which I'll reference later in this talk, but a ACCP guideline now which has been formed specifically focused on EBUS specimen preservation and acquisition to allow information for clinicians to provide additional detail and success in these procedures. So the cell blocks that we prepare provide the additional detail for intercellular bridges between squamous cells, and specifically to provide architectural patterns that are necessary for specific diagnostics. The cell blocks also can provide multiple slides in concentrated format for immunohistochemical staining. And as we've shown, tissue can be used for DNA mutations in fish, and clearly can provide improved yield and cellularity in one study here showing a 89% versus 56% statistically significant difference in cellularity preparation. Here's two study figures that I think nicely highlight. The study on the left is a study that was published at our center illustrating how we utilize the clot technique. So panel A shows a standard EBUS image with the needle in the lymph node. Once the needle is taken out, it's handed off to our technicians, who then work with our cytotechnologists, and utilizing the stylet, the specimen is passed out onto a piece of filter paper, which you can see there over multiple minimum of 4 passes using Rose guidance. We were able to collect the tissue aggregate, which then, once sectioned and preserved, can supply a very nice histopathologic sample. The figure on the right in a study by Nakajima and JTO, this is back in 2010. So a lot of these techniques have been around for a while, just illustrating all the different DNA methylation, FISH, and other techniques that can be utilized just using small needle, minimally invasive sample sizes. There is a constant debate, I think, that's really formed by the way some of our oncologic protocols are written, specifically focused on the need for core needle biopsies. This is hopefully going away as more and more data exists. So multi-societal guidelines state that biopsies of any cytology sample with adequate cellularity and preservation can be used for biomarker testing. So the need specific for a core should not be requested or written in protocols specific to lung cancer anymore. As I showed you, there are multiple methods that can be used to collect tumor samples for diagnostic testing and mutational analyses. And multiple pathology society and other societies have really convened on this, that we should all be using image-guided procedures. We should perform dedicated passes for ancillary studies. And the figure on the right here shows that a core needle biopsy versus an FNA does not yield a statistically significant difference in molecular analysis. And this study in specific fashion was really published and looked at before the incorporation of Rose and minimum pathologic pass techniques. So this should really be an equivalent procedure. This, I think, is nicely highlighted in a nice very much multi-societal guideline spanning a lot of different subspecialties: pathology, surgery, interventional radiology, pulmonary and cytopathology, specifically looking at collection and handling of all thoracic small biopsy and cytology specimens. Again, I highlighted earlier, the ACCP has initiated a guideline specific to EBIS for this, with a goal to really provide clinicians with a set recommended format on how to perform these procedures and what to do with the specimens. So to finish up, tissue remains the issue for staging, diagnosis, and therapy. EBIS and peripheral bronchoscopy are warranted for early stage diagnosis, and histologic subtyping, mutational analysis are critical steps in the evaluation in all patients with non-small cell lung cancer, utilizing now both EBIS and peripheral bronchoscopy. It's on us to ensure that we have enough tissue so that these patients can get and teams can get their results and therapeutics started and avoid repeat procedures and which are both costly, add risk, and delay treatment. And ROSE can be of significant benefit to help with this. Thank you very much. I'll hand this over to Dr. Silvestri in the panel, and I'll just highlight that the next ACCP AstraZeneca webinar on the role of pulmonologists in tissue acquisition, specimen handling, and molecular testing in late-stage non-small cell lung cancer will be held Wednesday, March 3rd at 4 p.m. Central Time. Thank you very much.
Lonny, thank you very much. That was fantastic. And, I really think when we talk to the rest of the group, it's just been such a roller coaster ride in terms of diagnostic yield for different techniques in early stage lung cancer. I want to remind our audience that you can go into the question and answer box in your Zoom and post questions. But while we're waiting for some questions to come in, I just wanted to talk to Daniella for a moment about this, landmark, I think, which will be viewed as a landmark study. And so some of the things in that study that Lonny didn't cover that I wanted to get through were some of the demographics of the patients and what you're seeing maybe in your practice, Daniella, at Sloan Kettering. First of all, the patients seemed a bit younger than our average lung cancer patients, which is 70. So these patients were on average 62 years old. 68% of the population of 600 or so, almost 700 patients, were never smokers. Their median pack year of the smokers was only 22 pack years, and 64% of the patients in this study were Asian, and 70% were female. So this is sort of this phenotype of what we've come to expect from EGFR positive patients: Asian, female, light to never smoker, with an EGFR mutation. Is that what you're seeing in your practice?
Yeah, exactly. It's very interesting how the landmark has really changed a little, the population of patients that we see. We see a larger number of women. We actually recently reviewed our database. We have now more women than men overall in our lung cancer database, which is pretty interesting. And we, of course, adenocarcinoma, light smoker, never smoker. And these are the patients that are seen to have more mutations. And so we have more options of treatment for these patients overall. So it's changing, so when you think about lung cancer, the way that we used to think about it in the past, I think things are changing significantly. So it's a very exciting time.
I don't know how many people you either have worked with this, but one of the things that impressed me about this study was about a third of the patients were 1B, about a third were 2, and about a third were resected stage 3A. Now, none of us go into an operation wanting to resect a 3A. Most of the time you go in, as Lonny mentioned, clinically with thinking it's a stage 1 and then it's resected. In your practice, is that about sort of right in terms of when you're looking at larger tumors, you're finding more micrometastatic disease to
right.
the 1B, sort of 1B patients or larger primary tumors? Are you finding those patients?
Right. So there are a few things that I think are very important today for us. You know, the old days for surgeons where you had a nodule and it's sorry, that's my dog.
All right, that's what Zoom does.
So you have, you know, in the past we had a nodule was suspicious. You take him to the operating room without even knowing, right, if there's cancer or not. And then you do all together there if it's positive for cancer on frozen. I think those days are kind of over, because now lung cancer diagnosis and treatments become so sophisticated, and we're really trying to be as aggressive as possible to obtain a staging, first of all, because if you know that the patient has N1 or even N2 disease, they have option for induction treatment, and I think they benefit from induction treatment. And also there are other factors, you know, as we're moving more to minimally invasive approach, and the lung sparing option is very talked about today. And there are factors that not just strictly related to genetic characteristics, but also the histology of the tumor that might push us towards doing a lobectomy versus a wedge or a segment today. They're very, very difficult to see or diagnose on a frozen section. So if the patient has a lot of micropapillary component or a lot of large solid component on the tumor, I'd be more lenient to do a lobectomy on that patient rather to do a segmentectomy, because those patients have a higher chance of recurring or even having metastatic disease of the lymph nodes. And I would not want to leave disease behind. So it is true, things have changed, and you know, the tumors are bigger, that are more higher ICUV numbers, but also type of histology tumor is important today for us to decide what kind of treatment we do overall. And so we want to have all this information up front.
So let me just ask you, in your tumor board, and Peter and Lonny can jump in here. You know, so I have my tumor board today, and there are times where, you know, the patient has a new or growing nodule. It has all the characteristics of cancer. It's hot on PET. The mediastinum's negative, and then there's this discussion about going directly to surgery rather than having a tissue biopsy up front. Given this new data, given what you just said, I've noticed in our place, Dr. Chad Denlinger, who's our thoracic surgeon for a while, he's just moved on, but he wanted a tissue diagnosis up front, either by TTNA or bronchoscopy. Are you asking for that in your tumor boards now?
Yeah, more and more often we do that. It's for all these reasons, you know, it's important to know what you're going into, but also to plan what operation you're going to do. And there are aspects of the pathology that are not, and maybe Peter can say more about that are not so well defined on a frozen section. And so you might miss some information that might be guiding what kind of surgery you do. So yeah, we are more and more aggressive with biopsying, not only of early stage, but even in recurrences, for example. You know, like even if we have information about the tumor on their initial resection, we want to know what's changed, what's different in that particular recurrent site. And so we are really very aggressive with biopsy, because then we can test it for genetic alterations and see what has, if anything has changed, and we can target treatment or change treatment based on that.
Great. Peter, you want to jump in there and talk about that as well?
Yes. So I think that depends on who sees the patient first, in terms of how often biopsy is done. If it's a surgeon who see them first and it looks like a stage 1A, they may go directly to surgery. Or if the question is not clear, or it's an area where it's very difficult to biopsy. And so I think we still will have those cases. And I agree, frozen section can be very difficult, especially if there's inflammation, and you know, it cannot be definite. And then so that limits what information you can give. In terms of molecular testing, we reflex test every tumor at Johns Hopkins, so we have that data, and that's our practice. But that's not the routine in most places, especially in the community. You know, molecular testing, especially you can do targeted testing, single gene testing, or more comprehensive testing. If you do comprehensive testing, it also has the advantage, if there's multiple nodules, to the molecular staging. And there's data in the literature I think it's quite well established now that molecular characteristic can be different from histologic appearance. So if they have two adenocarcinomas, it can change the stage, and also, so do that up front might be very useful. It also goes back to the recurrences. I think if you want to know, is it really a recurrence, or is it a different tumor, or is there a different target that you can utilize in the therapeutic approach? So I think this is what, from the pathology perspective.
But I think we'd all agree, I know that Sloan Kettering, because I know you're pathologists, they have tested every tumor for a very long time, right? Even if there was no target, even if there was no treatment option. I know Hopkins is, again, another research institution that does that. But I have to say, most people around the country were not testing early stage lung cancer. Most people were testing either stage 3, 4, or even just stage 4 metastatic disease, where they had approved targets. What I'm hearing from both of you, again, I want you to take it out of the ivory tower for a moment and tell me, do you think now, given this study, it is time to really start to molecularly characterize early stage disease?
You go ahead.
No, go ahead.
Ladies first.
I think from my perspective, yes, it is very important to stop treating patient in a cookie cutter kind of approach. Lung cancer has become very sophisticated, and we gotta to become more patients tailored, so tailor their treatment to the type of patient that we have. And we cannot just always do the same to everybody. And I think that's what molecular testing can help us with that, but not just molecular testing, even histological testing can help us with that. And so I think that having more information about the tumor cannot hurt us. It's just only going to help us up front before we decide what treatment is more appropriate for the patient. And today, so low risk is a procedure that it doesn't really have that much risk to the patient, that I don't see why we shouldn't do it.
Okay. I would agree with that. Lonny, do you want to add anything in?
So I think this has changed so dramatically over the past even 4 or 5 years, with situational awareness, both in the community and academic centers. So the number of patients, for example, that have been referred to Hopkins who used to just get a TTNA and then get sent to oncology or surgery here and then get sent to us for a staging procedure has dramatically decreased, right? So the surgeons, primary care physicians, pulmonologists, everywhere, there's a growing understanding of cancer staging and minimally invasive techniques, but also institutionally. So the number of referrals we get, as an example, from our interventional radiology colleagues, where they are still getting a referral for a TTNA and recognize an enlarged lymph node and shunt that patient over for an EBUS, right? So all of that has changed based on education and awareness that I think surrounds exactly what Dr. Molena is talking about, the minimally invasive nature of these procedures and the growing success from a diagnostic yield platform as well as a molecular yield is really what's able to drive this.
Yeah, I'm going to finish on this section just with a few other observations from that study that I think are incredible. One is, it looks like resected stage 3 patients, in terms of all patients benefited if they were EGFR positive and received osimertinib. It turns out that stage 3 patients actually did better than stage 2, better than stage 1B, which makes sense, right? Like if you're at risk for recurrence, you're more so with a higher stage disease than a lower stage disease. The other thing that was incredible in this study is when it did recur, in the osimertinib group, only 4% recurred with distant metastatic disease versus about 28% with the patients who just didn't have osimertinib. The last thing that was incredible to me was a 5 times higher rate of CNS metastasis. And I think that's one of the things that really swayed me about this study. And the side effect profile was reasonably well tolerated. I'm going to throw this back to Daniella or Lonny in that one of the other interesting things about this study, and then I'll end, is 60% of the patients received adjuvant chemotherapy. And so I guess what I'd ask you now is, in your tumor boards, if you have somebody that's EGFR positive who's resected, do they even get adjuvant chemotherapy, or just go with osimertinib out back and as adjuvant? Because we know from Tony Mock's studies years ago that if patients were EGFR positive and received gefitinib, they did better. But if they were EGFR negative and received gefitinib, they did worse, and vice versa. If they were EGFR negative, positive and received traditional chemotherapy, they did worse. So should we really be focusing going out now on just the right target for the right patient? I'll ask you first, Daniella.
Yeah, definitely. I don't see why we should treat patients with other type of chemotherapy that might not improve survival as much as this, data show to improve. So definitely we've changed completely. We moved to doing adjuvant osimertinib now.
Great. And I mean, the other thing we really haven't talked about is that with next-gen sequencing, it may be that we are looking at adjuvant therapy for some of the other markers, right? Like there's there's a new KRAS marker, ALK marker. Should we be doing trials in those markers to look for this tailored, personalized therapy? As you mentioned, lung cancer may be 100 diseases, not adeno or squamous, right?
Right.
Go ahead, please.
Sorry, I think that's what the future, because we really don't know exactly yet which patients are going to recur. And at this point, we go based on stage and the risk of recurrence. And that's how we select those patients that will benefit for adjuvant treatment. But I think the future perhaps is like being able to see the mutation in, the liquid biopsy and look at ctDNA presence of tumor. And then maybe we select those patients independently of their stage that are more at risk of recurrence to give them adjuvant treatment. And so we kind of move away from that, stage-based approach. And we're doing some trial right now. One of my partners is running a trial looking at ctDNA expression before and after surgery for early stage disease to see if we can identify the same mutation that are seen in the tumor. So that's, of course, down the road, but I don't think it's down the road that far.
Yeah, I think the data on early liquid biopsy, use of liquid biopsy in early stages is not mature yet. So, we have to investigate it. I think it's at that stage.
And so, Lonny, I want to get back to this issue of the non-operative patient with early stage disease. We, in our tumor board, a patient with emphysema with a positive PET and a growing tumor. We have the discussion at tumor board. We do always try to biopsy, but if you look at studies, up to a third of the patients in SBRT studies never have a biopsy before getting treatment. Certainly some of those may not even have cancer. But let me ask you, does the findings of this study make you start to think, I need to get a bit more aggressive about getting tissue, irrespective of if they're going to surgery or not? Lonny, could you answer that for me?
Yeah. And the answer is yes. I mean, we were already on a path of a little bit more aggressiveness, maybe that's the right word, guided by our radiation oncology colleagues for adequate staging in those patients, right? So every patient that was considered for SBRT will undergo EBUS, whether or not there are lymph nodes present or PET avidity to them. Many of those patients, historically, we did the EBUS and did not go after the primary because they were going to be treated regardless. I'd argue that's very different now, right? I mean, with specifically this paper, I think both, obviously the treatment modalities change, and it happens at a time where I think we're at a high level of hope and promise for our peripheral diagnostic techniques to help and improve utilizing newer technologies such as robotic assistance.
Staying on that subject, we're all lucky enough to be in centers where we have access to this technology. But I'm going to ask all three of you, because you get referrals in from outside institutions. how do you balance this technology in the community center, regionalization of care? Community physicians don't want to sort of, quote, lose their patients to the big bad black hole that is academic institutions. I don't think this is an insignificant problem, both in communication, but also in, and really difficulty for some patients to get to those places. I've always been an advocate of figure out what your local expertise is, use it if you can, and refer if you don't have that expertise. Lonny, I know that your practice patterns and your referral base has changed over time. Could you care to share how you manage this relationship between community pulmonologists and the university or any kind of expert center?
Yeah, that has also changed, pretty significantly. I think two pertinent examples is the availability of EBIS throughout the U.S. as an example, and the expertise of those providers. So 10 years ago, an EBIS bronchoscopist was not an EBIS bronchoscopist from center to center. I think what's changed now is there's been such an increase in experience that I routinely, colleagues at community hospitals in Baltimore that we know and work with, I think if you put an EBIS image video side by side of myself or one of my partners and them, you wouldn't be able to tell any difference. So I think the expertise and experience has grown. Where I do think there is still a gap is the pathologic assessment comfort at those centers. And the examples specifically, a local hospital in Baltimore that we collaborate with has about a 30% EBIS mutational yield versus our 90+%. I just told you that I don't think my EBIS skill is any different than theirs. So that difference is really, I think, in specimen acquisition, handling, and pathologic interpretation and advocacy to send those samples for and preserve them, right? So that's where I think there still is a significant difference between the university centers and the community centers. In the periphery, I think robotics, at least in our experience thus far, and some of the learning studies we've published recently, it's a procedure that it does, I think has a much shorter learning curve than traditional conventional bronchoscopy. So I think that in short order is going to provide the same benefit where these types of resources may not have to be centralized to larger centers. But with that, I think has to come equilibration of the outcomes and finalization of data like pathology, which I don't think is equivalent right now.
Peter, I want you to jump in there for a moment because I've recently talked to a pathologist on a different panel who said, there's a shortage of pathologists, and then specifically they're not as focused as you are on lung or maybe lung and head and neck, for example. And they sort of, in some ways, were saying, I don't know how we keep up with, this exploding need for different markers and everything else. What are you seeing coming into you from outlying hospitals, and what one recommendation do you make to your colleagues in those centers to improve their yields?
You see, it's true that there's a shortage of pathologists, but that's not in the head of administrators. So in Canada, the average case number for a pathologist has stayed sort of same, maybe has grown about 10%. In the US, it has grown by 40%. So, and the cases are more complex and bigger. So it's not necessarily the actual case number, but the workload has increased. The community pathologists have to do everything. So they don't focus on a certain organ system. So their work is more difficult in many ways. They are really good at diagnosing morphology, either histology or cytology. I don't see a major impairment there. But what they struggle with is to keep up with the new information of different tumor types and what they have to do. And another factor is that many community pathologists and administrators worry about reimbursement. And CMS changes the rules, and for instance, they say Medicare will only pay for 1 NGS per lifetime. So when do you use that? And in the new data that ADAURA trial has shown raises the possibility that should the community practice do a targeted EGFR testing only on a small biopsy, especially in an early stage cancer, or do the NGS and worry about the reimbursement later. The way this is reimbursed is that the pathology department or the pathologist has to pay for it if it's not reimbursed. So they're not gonna be enthusiastic about doing testing if that affects their budget. Now, the centers, the groups can work around this. They can create standard operating procedures and figure out a way that's legal and assures a reimbursement. The reimbursement rate is not that great either. So, but that's the case everywhere. So I think just knowing about that, talking to your colleagues, the oncologist who will actually decide what therapy to give, the surgeons, the pulmonologists, the interventional radiologists, and the pathologists, they have to communicate and they have to teach each other from their respective point of views of what do they need and what they can do to get the best result for the patient.
Daniella, so what I'm hearing both from Lonny and Peter is that communication is critical, right? Like, communication, we all work in teams. We text each other after tumor board, hey man, can you do this procedure for me? That's not always as easy out in the community. And so I wonder, Daniella, are you actually in cases now where you're doing resections where the patient doesn't have a diagnosis up front, are you alerting pathology that you'd like to order a next-gen sequencing panel? Is that reflex tested already, even for your early stage disease, or are you talking to your oncologist at tumor board after resection? Can you tell me what you're doing there?
Yeah, we're pretty lucky, I know where I am, because we have a very large research group. So every patient, whether they come through the door at MSK, gets consented for tissue acquisition and storage. And for lung cancer in particular, I'd say probably 80% would get next generation sequencing analysis. And so we have different type of analysis. We have our own platform that, we sequence over 500 genes. It takes a while to come back as a result, but then we have other more rapid tests that we just test specific, EGFR, KRAS, ALK, so the most common genes that we want to know about. So it's pretty easy where I am. So I can imagine that maybe in other places or in the community, it might be a little bit more difficult to obtain those information, those tests. We don't need to rebiopsy patients. Often if the patient has had a good biopsy, even out with a community pulmonologist or interventional radiologist, we can just use those slides. We just need 20 unstained slides to run all the tests that we need to have all the information. And I wanted again to say that it's very important, as everybody said, communication and collaboration. Patients don't like to travel. And, in New York, especially, people don't like to come to New York. We have several regional centers, and in the regional centers, we don't have all of the, support that we have in the main center. And so we collaborate very closely with the local physicians and local pulmonologists. And I think that's the key for success. Keep the patients at the end of the day, the patient is our most important thing that, we want to keep them safe, we want to keep them happy, and we don't want to make them too uncomfortable for traveling back and forth to faraway city.
Well, listen, it's 5:59. This was a fantastic program, and I really appreciate, the work you guys put in for me. I want to thank Lily Rodriguez at Chest for helping get this all set up. Dr. Lonny Yarmus for his great talk and presentation, and the conversation between friends, Dr. Illei and Dr. Molena. I honestly, the last thing I'll say was something that Daniella and Molena said, which is two things. The patient is at the center of everything. We have to work to make a diagnosis. And the second is communication. Find your friends in pathology and interventional radiology and thoracic surgery in medical oncology and in chest radiology talk to each other, develop care paths that will help our patients well into the future. And so I'd like to thank everybody. And again, a reminder that we are going to have another program on March 3rd at 5 p.m. Eastern time. That's going to look at late stage disease and the broader based molecular testing that we do. So again, thank you very much on behalf of ACCP, and thank you for the support from AstraZeneca, and have a good evening, and please everyone stay safe. Thank you.
Thank you.
Bye.
Thank you.